Thank you. I have one question, and then we'll open it up. There were a couple of, even in talking as we're preparing for this, a couple of, I would say, two themes that really stood out in terms of the things that you're grappling with working with tribal communities that also relate to the whole of the picture. And one of those is this idea of designing solutions to improve care with those for whom the care is intended. So that has been coming up a lot today. And it was clearly resonant in talking to you guys and preparing, but was a theme throughout. So I just wanted to name that. And then the other thing is really the workforce, the availability of the clinical workforce. And so when we've been thinking about where are the places where there's an intersection between, the potential to improve care, both for serious mental illness and for suicide prevention, and for how those intersect, including early identification and then also ongoing engagement. Each of you has had some examples of how there have been kind of workforce solutions. And even within your presentations, you talked about them sometimes as though they were workarounds or like compromise solutions. But actually, you also described them in ways that really, they were strengths. And the fact that it ended up being that particular community of people who were providing services in some way and being a bridge into the more formal clinical care services is actually a strength of what you described. So I just wanted to ask any of you who would like to, if you have thoughts on what would an ideal kind of training staffing matrix look like for this space? For this space in which you have, communities with a lot of people who are vulnerable and who might be in need in both of these areas of serious mental illness and in need of behavioral health care, and specifically with suicide prevention. What would be your, if you could wave a magic wand and say, this is how people should be trained and this is how it should be staffed, and that's how those relationships should work. Down below, there's the right side.
Okay. Can you guys hear me? Sorry, I have to speak up and directly into this, I think, for you guys to hear me. I think it is probably pretty unique by, where people are located. But I think there's a lot to be said for behavioral health. But the piece that I always go back to is I think about a lot of the programs and the evidence-based protocols and things that are out there, and a lot of their origins are in indigenous knowledge. So I feel like there's really something to be said that we really have the knowledge within the community, but I think that we need structures in place to build for those. So that is one way that, working with the tribes has helped, but there are a lot of barriers within that as well that can complicate things.
I don't know if this really addresses your question directly, Bridget, but in order to build that workforce, we really have to be starting early. We can't just start when kids graduate from high school or even when they're in high school. We have to be starting by building awareness and engaging kids when they're little wee ones. We do have the Alaska Native Science and Engineering program at the University of Alaska in Anchorage, and I don't know if it's at UAF as well. It is? Okay, so it's a UA-wide program. It's heavily focused on engineering, but I had an intern on my research team who was a member of that program and is going on to medical school. And we have had interns and staff in our department who go to NIH Week, who participate in a number of different STEM programs. I think that building the workforce happens in all kinds of ways, like Laurelle was saying, and I think that we need to focus on both those kind of conventional, traditional science and medicine pathways, but very, very early, because many of these kids are going to be the first in their family to ever leave their family or their village and go to college. And we also need to be focusing on the quote-unquote non-traditional, although they are very traditional pathways, and validating them with our Western scientific tools and techniques and knowledge so that we can build a cultural evidence base that can then become funded. And I think that's going to be a long uphill battle, but I think those of us who are non-native researchers and stakeholders, we have a big role to play in that, in fighting that battle.
Yeah, I think each of the projects have demonstrated these interventions also are required to be capacity development interventions, and that's part of the picture, and the solutions are within. And the communities have the cultural knowledge and, have a past history of success. And all the approaches you're hearing draw from local people who have the credibility, who have the cultural understanding, who have the relationship of the trust of the community. And we found, beginning with that, is crucial to being an effective provider, and are the people that need to be supported. And each of these approaches describes building in training and professional advancement to the staff as an important part of their models.
The only thing I would add is, tribal communities no community in the United States can afford to wait to downstream, to let all this treatment need pile up. And right now we have great opportunities for early childhood intervention that are intergenerational. And we know that the risk and protective factors start then, when someone is pregnant and the family is forming and they're nestled within multi-generational homes. And that is true in all poor communities in the United States and abroad. So we still have the Affordable Care Act that is supporting home visiting intervention. I think we should be looking at that as a means of suicide prevention, number one. I think number two, we have within the Indian Health Service, public health nursing and community health reps. The community health reps are now on the chopping block. Legislation is really gearing up to maybe get rid of CHRs, which would be a tragedy. What they need is better training and a larger package of training modules to address everything from suicide to diabetes, because they have that capacity. And public health nursing have health techs within their workforce. So there's already federal funding streams that are supporting these different levels of workforce that can be well integrated into the mental health system. And I think that's the future for all communities. I live in Baltimore. We need mental health aides in our communities, for sure.
It's a bit of a bridge question to our next panel, just for some foreshadowing, which is really going to be diving into the perspective of providers and how their relationship to the systems, supports their work kind of along the continuum of care. So I think we might have some questions from the web audience.
We do. So this question actually came up during the first two panels also, but I think it's very relevant to this one as well. And that is talking about telemedicine and how that has a place in your programs. And I think it was only Laurelle that mentioned telemedicine that I've heard. But this also goes to an issue of workforce too. So maybe you can all talk about the effect of that, or whether that's a viable solution.
So at Southcentral Foundation, we use telemedicine heavily to provide services to our 55 rural communities. So we have we have teletherapy, we have tele everything, as far as I can tell. I'm always learning about some new way that technology is being used. In fact, now there's even in some of the community clinics they have, and I had for a different presentation at NINR a couple months ago, a slide of this like vending machine looking thing that has medications in it, and it's locked in the village, and then when the primary care provider sends the order, it goes through the whatever ether, and it unlocks and dispenses that medication, and it's all on camera, so you can see the community health aide pulling it out of the slot and handing it to the customer owner. It's kind of magic to me. So we are using telemedicine a lot. I don't know if that gets. I don't know really what the question about it was, or if I got there, but It's a big thing. I mean, when you're it's also, I'll just say that's also why our behavioral health leaders chose caring contacts. Out of the 5 interventions that we presented to them when Kate came up, Dr. Comtois, 6 years ago, and they chose caring contacts because it's positive and it builds protection or resilience or whatever we want to call it. It focuses on making people stronger and more connected, and it can be delivered cheaply over distances. And it doesn't require people to travel hundreds and hundreds of miles when they're in crisis, because we can prevent that by providing care when they're at home. Also, I will say telemedicine is also an important part of workforce, because it means those community health aides and behavioral health aides and dental health aides, we have 4 levels of dental health aid, they can stay in their home communities where jobs are very, very scarce, and they can be a productive, purposeful member of their community. And we need more jobs like that, so that those few people who have them don't become burnt out by becoming, the people that are always providing the care in the community.
So I wanted to ask if you could just elaborate on a couple of things that were mentioned in your presentation. So Allison, you mentioned, if I understood you correctly, that part of the approach or protocol involved literally going to community members' homes and asking about suicidal, whether anyone there was thinking about suicide. If you could elaborate on that. And then Southcentral, if I understood you correctly, it sounded like there was a case management program that really focused on those who were thinking about suicide. So I'd love to hear more about each of those.
Yeah, so the original system, the case management system, is a home-based, school-based, meet the person wherever they are. And because it was found that was very much welcome. There was no one slamming the doors when these, people from their communities were showing up and caring for them. So there was a little blip in suicide deaths, and the behavioral health department got together with the Celebrating Life team, and they said, let's go door to door. Let's just go canvass these neighborhoods that we're seeing all these deaths in. And so now it's happening on an annual basis, where they're going door to door and saying, this is our suicide hotline. They're giving them resources and saying, we're available to you if there's anyone that you need to see. But they go ostensibly to deliver, like, these are the available resources to you. And then if you need me now, I can stay. If you need me in the future, I can come back.
I'm going to punt your question to TJ, who's going to be speaking in the next panel, because he's the clinical supervisor of that program. I'll just very briefly say that Denai Yeats, I think you still are, right, TJ? I don't know. We change roles so often. Yeah, we play musical chairs at SCF because we all want each other's jobs. But it's a case management program. Denai Yeats means breath of life. People who are at high risk of suicide, enroll in the program. They come and they do activities. People check in on them. One of the studies that I mentioned was doing in-depth interviews with 15 people who had experienced suicide risk ideation and or attempts. Some one time, some multiple times for many years. And multiple people in that study were enrolled in Denai Yeats at one point or another and spoke about it, the critical role that it played in keeping them alive. Just by knowing that somebody was going to check in on them, by the connection that it provided them to cultural activities and cultural connection and connectivity to their heritage, to their people, to their community, to the things that feed their soul, was really, really important for people who struggled with severe anxiety, with severe depression, and all the other things that, we talk about in as proximal risk factors. And it really, I think, gets to some of those a little bit more distal factors that provide people a sense of well-being and don't require them to be in the hospital. So.
And did each of you also describe a case management model in your behavioral health services, regardless of identified suicide risk, for managing mental illness? Did I capture that from both of your lists as well?
Yes, we do care coordination and case management. We have about 5 patient advocates, we call them, who can support people just generally with any resources or and also specific to behavioral health care coordination.
Any other questions? Of course, please do.
I would feel really remiss if I didn't mention, this is just a little bit random right now, but we've talked a lot about the intersection between suicidality and substance use and misuse. And I just want to mention that, you know, while some Alaska Native and American Indian communities have high rates of alcohol use and substance use, they also have the highest rates of abstinence. And so it's a bimodal distribution that oftentimes gets lost in those discussions. And somebody mentioned I think it was Allison, that we don't have really good epidemiologic information on rates of serious mental illness, but I wouldn't be surprised if we didn't also find if we found the counterparts to those, symptoms and risk factors, so to speak, that if we didn't also find a bimodal distribution there. I went to Alaska to study suicide among youth, and I quickly realized that I wasn't going to be able to do that as a non-Native outsider who had no relationship with the communities. But after living there for just a few years, also realized that wasn't what needed to be studied, because all of the reasons why people were talking about and listing in the literature why Alaska Native youth were at such high risk left me wondering why everybody didn't want to kill themselves. I mean, if you read that literature, it is downright dismal. And I thought, these kids, there must be something really right going on in these communities to be raising kids, not all of whom are going on to do well, but many of whom are thriving, not just surviving, but thriving. And so instead, I ended up, through many conversations with elders and community members and kids, studying the role of traditional subsistence cultural activities in their well-being, and then got my job and was promptly assigned to a bunch of suicide studies. But I think we need to remember the other side of that coin, and we need to be looking for those counterfactors anytime that we're looking at any kind of risk or, for lack of a better word, and jet lag right now, the negative factors. We need to also be paying attention to and looking for that white space that maybe isn't filled, that we maybe need to start paying attention to and putting more money into understanding, because I think that's where we're really going to find the solutions.
Thank you. Well, thank you very much to all 4 of you. I appreciate both the breadth and depth of the responses that you provided. We're going to take a short break and reconvene at 4 p.m. And this next panel is going to, I think, bring us back full circle in terms of tying together some of the themes, the more general conversations this morning in these specific populations. So I suspect we're going to pick up a lot of the threads and really hear about them from a very grounded perspective in terms of actually providing care to these the populations that we're talking about. So we look forward to that. And we'll see you again in here at 4. Quick break. Thank you.